So now we'll move to next session on staffing considerations for crisis standards of care. And I'm joined by four esteemed colleagues. First of all, Tenor Venema, who's a contributing scholar at the Center for Health Security and a professor of nursing in the Johns Hopkins Bloomberg School of Public Health. Greg Myers, President of the Community Division and Executive Vice President for Value-Based Care at Mass General Brigham. Mike Wargo, Vice President and Chief Enterprise Preparedness and Emergency Operations for HCA. And Asha Devereaux, who's a pulmonary physician in Southern California and is on the ACCP Task Force for Mass Critical Care and is a Senior Medical Officer in CalMet. So with that, I think we're going to start with Tenor first with a brief presentation.
Thank you so much, Eric. I appreciate the introduction. Let me first say greetings to everyone, and it's certainly an honor and a privilege to be here with you today and to extend our discussion on staffing considerations as we think of all the work ahead that needs to be done with respect to crisis standards of care. I want to start off, first of all, by acknowledging my colleagues on the planning committee who worked to develop the second webinar where we specifically addressed staffing and also prepared this presentation for you today. So Dr. Devereaux, Dr. Myers, and Mike Wargo all contributed to this presentation, and we'll be chatting with you over the course of the next 25 minutes. So our goals for this particular section of the webinar are to reflect upon and characterize for you the challenges and opportunities that were presented in the second webinar, but also to take what we've learned, the evidence we heard, what we all have been witnessing over the past 20 months, and really articulate potential opportunities to enhance crisis standards of care, the framework for it, the guidance for planning, for activation, the triggers for implementation, and how we can think about evaluating and monitoring it going forward. We know we need to do a heavy lift going forward, and I thank Dr. Hunt for setting the stage for this presentation in terms of thinking about not only future staffing considerations to support surge in crisis standards of care, but because of the situation we find ourselves in today, to really think about the long-term impact on the healthcare workforce of what has happened during COVID and what we're going to need to do to move it forward. So certainly there is a very significant research agenda ahead related to informing what this framework, a revised framework for crisis standards of care should be. What work is ahead that we need to do in order to plan, activate, implement, and again, evaluate and monitor crisis standards of care during future public health emergencies and other pandemics. Next slide, please. So in order to develop our presentation for you today, in order to sort of have a framework for how we were going to approach it, these were the questions we asked ourselves as a group. So what did we hear during that first webinar that confirmed what we already thought was true? What did we hear that challenged our thinking or brought up some issues that we hadn't even considered? And then what are specific ideas, issues, strategies that we should definitely be taking into account as we move to craft the next iteration of the CSC framework and its guidance? And finally, how are we going to achieve these? It is going to be a very heavy lift. There is so much work to be done, and I would posit that there are action steps that we need to take sooner rather than later. And finally, what do we think a national framework that includes staffing for crisis standards of care should look like? Next slide, please. So let's touch base again on some of the things that we heard that confirmed what we already thought. And certainly above and beyond, the message that we heard was that the extent of the disruption to the healthcare workforce during COVID-19 has been profound, as has the physical and mental health burden across all disciplines: physicians, nurses, respiratory therapists, emergency medical technicians, our students, medical students, nursing students, and our residents and interns. All have really borne a very, very significant burden. And this has been reinforced by survey after survey. 30% considering leaving the profession, 60% reporting a sense of burnout, exhaustion, depression, sadness, loneliness, and lack of optimism about the future. We've seen that Dr. Hunt already mentioned the confusion over the difference between moving from contingency to crisis and the allocation of scarce resources decisions that have been left to providers at the bedside. We heard a lot about the travel nursing industry and sort of the perversities that it's created in solving some staffing crisis, but creating such a sense of disruption and betrayal between nurses and the administration they work for. And then, of course, early on in the pandemic, providers were furloughed or sidelined, which, of course, contributed to increased numbers in these alternative agencies or work settings. Next slide, please. Some of the things that challenged our thinking, we certainly saw that there was much more inflexibility in our staffing patterns and a real constraint on our ability to mobilize and deploy staff to where they were truly needed. We saw that we were not very good at projecting where staffing needs were going to be and how we could identify resources available to meet those staffing needs. We certainly saw a critical need for more cross-sector collaboration. EMS, public health, emergency management, and all of the healthcare disciplines were forced to suddenly work much more closely together, even at times where roles and responsibilities were overlapping or were not clearly defined. We saw a true danger to the loss of team cohesion, particularly in emergency and critical care settings, where healthcare workers build their high-functioning teams on a sense of trust and understanding each other's skill set and competencies. This really had a negative effect on efficiencies and ongoing trust in many units across the COVID-19 pandemic response. Next slide, please. So to start off on what our future framework needs to look like, we absolutely need to optimize our use of technology across the board, not only for communications and documentation, but to drive its use to resolve and alleviate the staffing burden that we have witnessed. We can use it to innovate nursing care delivery, including telemedicine, telenursing, the establishment of tele-ICUs, to extend our healthcare workforce, to improve our oversight of critically ill patients, and to basically even out and share some of the burden. We know we need better data collection. We know that when we have better data, more current, valid, timely data, that we need to be able to share it with all relevant parties so that it can be used in a real-time, immediate manner. We have a long way to go to improve our collaboration and communication across entities that need to cross state borders. So whether it's scope of practice issues, whether it's challenges to patient load balancing, whether it's insurance restrictions on EMS providers, this is a whole issue that needs to be investigated and addressed. And finally, we need to build in the ethical framework for allocation of staff as a scarce resource during crisis standards of care implementation. Next slide, please. We saw examples from a number of large integrated healthcare systems on actions that they were taking for immediate strategies, short-term strategies, and long-term strategies. But I go back to some of Dr. Hunt's comments. This is a big issue. We are seeing the inflection point of two concurrent crises happening at the same time right now. We have the Delta variant and the surge of unvaccinated patients, but we are also experiencing a crisis in the healthcare workforce. Physicians closing practices, suicides being up, nurses, the hospitals hemorrhaging nurses. We really must look beyond some of our short-term immediate solutions to look at how do we correct perversities in compensation packages? How do we build in respite care to the healthcare workforce in order to give them time to take a deep breath and build strength and resilience? How do we look at that pipeline of medical and nursing students, not only funding it, as we've seen the House recently passing the Build Back Better Act with a significant funding, for example, for nurses, but how do we fix the healthcare workforce so that we don't continue to hemorrhage staff because of such a negative working environment? So on that note, next slide, please. And I'd like to turn it over to my colleague, Dr. Meyer, to continue the presentation. Thank you.
Great. Thank you, Tenor, and a special thank you to all who are participating in the webinar today or watching this recording for what you're doing for patients and communities around the country. And a special thank you to my colleagues and the National Academy staff who helped arrange this webinar series so we could all learn. We're going to talk about a few of the highlights of what we did learn from staffing, and also not just in the staffing webinar, but the reflections on how some of the other webinar topics actually had implications for what we did on staffing. One of the first things is to really deal with some of the challenges that Tenor spoke of in terms of trying to preserve our workforce, and that notion of trying to make sure that we don't lose our balance, that balance between resilience and workplace stressors, so that we're kind of falling off the edge. Because I think in many ways, our colleagues have felt as if they've fallen off the edge during the recent pandemic. One of the things that we learned in the seminars was that notion of trying to really attend to what is our Maslow's hierarchy of needs among our colleagues. And that includes things like ensuring that folks are sufficiently prepared, that they understand what the crisis standards are, that they feel supported while they have to go through what is a challenging time. They feel protected. That notion of safety as a fundamental construct here, that folks feel that they can go to work safely, and that not only for themselves, but for their loved ones that they come home to, that we're providing the safest possible work environment that we could under the circumstances. That they're cared for, and that care extends not just during their time in the workplace, but for caring for them in the home as well. And finally, that they're recognized, that they feel that they are honored for the work that they do. And so this, slide that was pulled from that staffing webinar, I think is a great touchstone for us to go back and say, here's what we need to do to ensure that we keep that proper balance as we go through, what has been an ongoing challenging time, and frankly, what is going to continue to be so. Next slide. We came up with a number of foundational elements for the future framework, and many of these are building off of what was previously mentioned. That notion of trying to be able to create and sustain a safe and supportive workplace setting that attends to all of those different needs that we talked about in the prior slide. To acknowledge that nurses and other caregivers, that there's staff that must be recruited, developed, and actually nurtured during these times. To make sure that we are supporting diversity, equity, and inclusion as not just as this is a nice thing to do, but frankly, it is a fundamental part of our ability to respond to these challenges that we've, again, faced so dramatically recently. In the middle here, there are several that relate to that notion of inflexibility that we encountered during the pandemic. And as you think about how can we do better to ensure that we can move staff to where we need them, to be able to pivot quickly. One of the things that I reflect on is the opportunity to learn from our military colleagues who are guided by a simple mantra: Semper Gumby. always flexible, always flexible. We need to be able to appreciate the limitations of what we can do just in time, noting that just in time upskilling was an important part of our response. But what are the limits of that? How can we do it even better? Load balancing among different caregivers and nurses are highlighted here, but it cuts across the entirety of the caregiving staff to say, what can we do much better next time? For example, we've had such an explosion over recent years in the use of technology like tele-ICU, but we probably under-leveraged those skills in terms of trying to level load during the response to the pandemic, and then trying to increase preparedness and understanding for the crisis standards of care. You heard in our keynote address that notion of, well, the first thing we need to do is we need to let people know about the crisis standards. Next slide. There are a number of important administrative concerns, and these aren't just for nurses or for physicians. This really applies to much of the workforce, although we see it most right now in terms of the nursing workforce. The first is addressing the perverse payment structures that finance the nursing and technical workforce. And in many ways that we kind of set ourselves up for failure by perhaps reliance or over-reliance on traveler and agency staff. Trying to think about how we can invest differently. Most of us would not have guessed, 2 years ago that in fact providing childcare is absolutely essential to our ability to respond to a long duration event. The reality is that when we're experiencing a long duration event, it's probably going to be impacting those schools. When those schools shut down, folks need an opportunity to provide care for their children, for them to be able to stay in the workforce. So what was in fact something thought outside of our purview in the past has come front and center, that we need to attend to those issues. We need to build greater resilience. And I think many of us in the past have always thought about the application of crisis standards of care in terms of hours, days, maybe weeks, but not many of us thought about them coming off and on over the course of months to years. That notion of having made eye contact and confronted a long duration event, that what do we have to think about very differently, really recognizing that may be in our future once again. And finally, what are the existing fora that we have? Where are the opportunities where we currently have groups locally, regionally, at the state level, and at the federal level who are currently engaged with each other? How can we add crisis standards of care to their ongoing dialogues so that we are leveraging them in our time of need, not having to build a whole lot of new structures when in fact we have some of those structures available to us today, if only they knew that this was part of their remit. Next slide. Some other things that came out of various webinar discussions are that notion of trying to ensure that we have a federal overarching coordinating body. And this, again, gets back to what you heard in the keynote. It's not the notion that the federal government's going to come in and have all the answers, but they can certainly do much more for coordination. And one very concrete step that has been called for in the past, and I think that would be endorsed by many of us who have had these discussions over the last several months and over the last year, is that notion that that the Assistant Secretary's office, for preparedness and response, that they become a 4-star equivalent. What that means is that they will actually have the scope of authority to mobilize the resources that are necessary to respond to what is a long duration event. And this central body could provide a pulse check, because that notion of being able to know, where are we at in terms of the workforce? How are we doing in terms of resilience? Are we starting to get to the point where we're facing a crisis? Do we have the ability to leverage what would be a national response, for example, to agency staff nursing agencies, to be able to ensure that we are not running into a situation where we're entering into bidding wars, which do nobody any good and frankly lead to bad allocation of resources across the country. And then the notion of collecting that data and sharing it so we know where we're at in terms of planned departures and the rest from the workforce. All of us who have made eye contact with the current nursing workforce across the country, and in particular the number of nurses who are slated to retire in the next decade, know that this is really a crisis that will once again be compounding whatever crises we face in terms of new pandemics or crisis standards of care situations in the future. Next slide. Finally, to finish on a couple of notes before we move to your questions, the notion of trying to learn what we can from harnessing e-technology is such a jump forward in our ability to provide virtual care during the pandemic. Good news. Bad news, we've been able to apply it as well as we should to making sure that we have the staffing possible to really meet the needs across a wide region. In the past, we've always had limitations when we try to think about space, stuff, and staff. Well, we have space and stuff limitations still, but our ability to move staff over time and space virtually is something that we've never been able to harness in the past. And maybe we can be relieved a little bit in that third S in terms of our response by leveraging technology. That notion of having a national framework committee and ensuring that we have the ability to communicate with each other and with our patients in our communities in an automated, reliable way. And then to really be thoughtful about the burdens that we place on our providers. What is just the documentation that is needed so that we don't have our providers spending their time filling out forms and clicking electronic health records when in fact we need them at the bedside delivering care. So thinking through what are the crisis standards for documentation, ongoing challenge for us. And finally, research and process improvement. We know that the issues that we've touched on here today are just the beginning of what needs to be a longer dialogue, and thinking about how we can use technology, how we can improve situational awareness, how we can use coordinating bodies to do better next time is part of the work ahead of us. Thank you.
Thank you, Greg, and thank you, Tenor. I'd like to invite Mike and Asha to join us and come off, put up your pictures. And I want to remind the audience that you can submit questions. There should be a box below the live feed. The National Academies would appreciate it if you included your name, affiliation, along with your questions and comments. So with that, Asha and Mike, any reaction to what you've heard, any comments that you wanted to make? Please, the floor is open to either one.
Eric, I'm happy to. One of the first things that I wanted to talk a little bit about was the true integration of healthcare and public health as a system. This pandemic really showed us that we have a divide between our healthcare, public health agencies, and a lot of health hospital systems. Tenor talked in the beginning about the cross-sector reliance, and even though we're within the healthcare sector, I think we have to have a stronger bond between our public health leaders and our healthcare executives so that we understand the prevention, the mitigation, the surveillance and awareness of potential disease and as the epidemic continues, and how we best prepare our workforce. In doing so, one of the areas that I think that we need to have another look at is our healthcare incident management system, or HICS rather, healthcare incident command system, and more align that directly with our everyday business and operating model within the healthcare systems, so that the work that we do seems to be routine. So we're not standing up command centers only during crisis, but we're using this to balance our workload, using this to help manage our staffing crises throughout, but educating our healthcare leaders more on this model versus the traditional HICS model that adopts a lot to public safety. This all comes together as kind of a unified model in how we manage our everyday surges, where we have a constant surge and then we see spikes and we can use resources to better allocate resources in that cross-sector model. And then the last 2 points I'll make is really embracing our future workforce and looking to academia. And I know Tenor has done a lot of work to talk about the curriculum and how we can look toward our future nurses by educating them on crisis standards, on emergency management for healthcare systems, but giving them an opportunity as student nurses and student healthcare providers to understand what crisis might be and what to expect. That'll help change the culture of the future workforce. And as Greg just mentioned, we've got a lot of healthcare providers nearing retirement. We need to embrace that experience the best we can for our Medical Reserve Corps. I think we let the MRC go stagnant for some time. And then we had this dependency where we truly needed them to support us on the public health side of things, and then acutely within the hospital and the surge. If we can really embrace that experience and that staff to enhance our Medical Reserve Corps moving forward, I think that would be great. And then the last thing I'll say is we truly need that unified mission and vision across all sector leaders as we move forward. If we can educate academia, if we can look at the cross-sector leaders and share a common vision of what crisis might look like in the future and how we can come together, given the lessons learned, I think we're going to have better outcomes as we move forward. So with that, I'll turn it to my colleagues.
Hi, Eric. I have a final comment, and thank you. This was excellent to my colleagues. Outpatient providers and entire outpatient workforce has been left off the table, and crisis standards of care happen in the outpatient world, whether patients self-selected to start hospice at home and did not want to go into the crowded hospital setting. And we have to reach out there as well. They will need our support. Over.
Thank you, Asha, and thank you, Mike. Well, we're at the end of our time for this session. Sorry we didn't get a chance to get to any questions, but it's because the presentations were so good. So we will now take a 8-minute break, and we will reconvene at 1 p.m. Eastern time, and we'll talk to you again in a few minutes.